Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. We're lucky to have Amber Radtke on the podcast today. She has her master's in athletic training certified, and is also a National Academy of Sports Medicine corrective exercise specialist. She joined MedStar Sports Medicine in 2016 after spending 4 years as an athletic trainer at Winthrop University in Rock Hill, South Carolina. Amber is currently the community liaison for MedStar Sports Medicine. She is also currently the head athletic trainer for the USA Lacrosse Women's Sixes team. Prior to taking on these roles with MedStar Health, she was a head athletic trainer at CCBC Essex. We're very excited to have Amber here today to talk about her ACL story and how she works with athletes post-op ACL. This is editing Becca chiming in before we actually bring Amber on because, admittedly, I wasn't sure when this would air, but it's March, which is National Athletic Training Month. Perfect timing. I've had the pleasure of working with athletic trainers for over 20 years, both as an athlete and as a professional. Athletic trainers do much more than work the sidelines of games. Later this week, we're going to drop a bonus episode with one of our athletic trainers to talk about all things athletic training. But until then, please enjoy Amber's story, and the next time you see an athletic trainer, thank them. Thank them for all that they do. They put in endless hours and serve so many roles in healthcare. They deserve a lot more credit than they get. So from me to you, thank you all the athletic trainers out there, and please enjoy the episode. Amber, welcome to the podcast. We're really excited to have you as an athletic trainer who has lots of experience with ACLs. I wanted to just start by asking you kind of how did you get into athletic training?
Thanks for having me. I'm excited to chat with you. And so back in high school, I played soccer and ended up tearing both my ACLs. So the beginning of my journey started there. I spent a lot of time in the athletic training room and in physical therapy. And I'm from Michigan originally, and I always wanted to go to the University of Michigan. So there was really no other option, in my opinion. When I was applying to school, I didn't realize you had to apply to a certain school within the university. I thought you just applied to the University of Michigan. So when I realized that, I was like, oh, which school do I want to be in? They had a school of kinesiology, and I was like, oh yeah, this is what I want. They had a movement science major and they had an athletic training major. And I was like, oh, I'm going to do athletic training. I think it'll be cool to get some hands-on experience. But I always wanted to go to a PT school, or that's what I thought. I took all my PT prereqs, like took summer classes so I could do orgo and stuff. And then between my junior and senior year, I kind of had this existential crisis where I was like, oh no, I like athletic training. Like, I think I don't want to go to PT school anymore. And it totally threw me for a loop. So my senior year, I applied to a couple grad schools, but I ended up doing an internship at Northwestern University with men's soccer and women's fencing. So I know more about fencing than the average person probably needs to know. But it was a great experience there. Went to grad school at University of Kentucky, and then I kind of just meandered around college athletics for a while and then landed up here in Maryland. So yeah, hurting myself was the initial impetus to becoming an athletic trainer.
So you said you have a little history with an ACL yourself or two. Can you go a little more into that and how that has changed how you work with these athletes after they have surgery or tear the ACL?
Sure. So my first time that I tore it, I was 14, which is fairly common for females. And I was playing indoor soccer. It was a non-contact injury. I honestly felt really stupid because I kind of just tripped almost, and no one was around me, and ended up tearing my ACL. So that night we went to an urgent care, like most people do. My knee was all swollen and obviously something was wrong with it. Got an x-ray. They were like, yeah, you're fine. Here's a straight leg immobilizer. You'll be fine in a couple of weeks, carry on with your life. Well, we didn't, know any better. So we did that. And, I felt okay, but obviously I still felt kind of unstable. And my varsity soccer coach he had just torn his ACL and had surgery. And he was like, I really feel like you should see an orthopedic surgeon. I don't know, this doesn't seem right to me. So a couple months later, finally went to the orthopedic surgeon, got the MRI, and confirmed that it was a torn ACL. And honestly, when in the office, they were like, "You tore your anterior cruciate ligament," and I was like, "Okay, cool." Like, I was like, "No big deal." Well, then when it dawned on me that that meant ACL, which was like a trigger for a female soccer player, I was like, "Oh no, I tore my ACL." So part of my big, like, as an athletic trainer, I want to help people navigate the healthcare system, because for me, we just didn't know like how to do it and what you needed to do and what you should be looking for, or advocating for, in those kinds of situations. You go to the urgent care and they're like, yeah, it's not broken, but there could still be something else going on. And so, that's one of my big things. And one of my roles at MedStar is to help people navigate the system and help it move efficiently and effortlessly, so they aren't waiting months before they figure out what's going on.
I've seen more and more lately. Too many patients come in and they say they went to an urgent care and they were told they sprained their knee and that was it.
Yeah.
And then more time goes by and they try to get back to a higher level of play and they can't because they're having these instability episodes. So, yeah.
I think like most people don't realize, I mean, you can be pretty functional with a torn ACL. I mean, there are people who are copers in the world, we call them copers, who carry on with their daily life with a torn ACL. One of our coworkers actually, she tore her ACL when she was 9 months pregnant, and then never ended up having surgery on it, because she's like, I mean, I can do all the things I need to be doing. So I think it's just really like depends on what the kinds of activities you want to be involved in, and your age. There's a lot of things that go into it, but you can be pretty functional with a torn ACL. So
we have a whole podcast. I just interviewed someone on copers and non-copers, so we're getting into that. Yep, that's awesome. As far as like when an athlete tears their ACL on the field in practice in the game, you're right there. What's their initial reaction? Like, is the athlete usually freaking out? Are they crying? Are they screaming? Are they kind of quiet? What do you experience?
Yeah. So I'm going to be honest. There's kind of something that I consider to be pretty standard, and I think most athletic trainers would. It's kind of like an ACL scream. You hear it, and I can't really describe it to you per se. I've just heard it enough times that it's like in your head. You hear it and you're like, they just tore their ACL. I mean, obviously I'm on the sideline, so I'm watching and I'm, I see exactly what has happened. Most of the time it's non-contact for most people, and it's some sort of, pivot twisting mechanism. So you can usually tell just from what happened, the mechanism, that they tore their ACL, but usually there's this like scream that happens and you're like, oh yeah. So get on the field and, generally I don't think most people aren't like freaking out. It's definitely painful, but they're like, okay, my knee hurts. And then once they kind of sit there for a second, it's kind of like when you sprain your ankle, it hurts. And then you're like, okay, maybe it's like, okay, and I can walk on it kind of, and it starts to subside. And that's kind of how it is. Like at first they're like, oh yeah, that really hurt. Most people will say they heard or felt a pop. I feel like that's pretty standard across the board. And again, they might not be able to really describe it. They're like, I heard something weird, or I felt something. Usually they can ambulate off the field with the assistance of somebody else. So coaches will help and we'll kind of carry them a little bit off the field. And then I'll do more of an evaluation on the sideline. I don't usually do a big evaluation on the field because the idea is kind of to get them off so that they can continue the flow of the game. And then we'll eval on the sidelines. I think from an athletic training perspective, it is depends on how well you know the athlete, depends on a lot of other factors, whether you're going to tell them right then and there that you think they tore their ACL, or if you're going to wait till a little bit later. When you work in college, you are usually with one or two teams. You know these kids really well. I usually say, like, I'm concerned about your ACL. I'll usually be honest with them. When you're working high school, and it might not even be your kid, it might be the opposing team that this happened to, then you're like, well, there's a few things that we're concerned about. And you kind of try to tell them, the ligaments in your knee, the meniscus, these types of things that we might be worried about. And then when mom and dad come over, you can give them a little more detail. So yeah, I think it just depends on how well you know them before you are going to lay it on them.
Do you think part of that scream is like part pain, part, oh no, I probably did something bad to myself, and it's like freaking out. Like they sort of know what's coming because a lot of their teammates have torn their ACL and they're like, ugh.
Yeah, I think it's definitely both. I think especially for your first one, it does hurt. And I can say from experience, the first one hurt a lot more than the second one. The second one, I was like, I just tore my ACL. Like it was, I knew exactly what happened. It was the other side. And I walked off the field. I drove my car home. It was my right knee. And I was like, I can drive. I know what's going on. So the other part is, yeah, once you do something, sometimes the next time it doesn't hurt as bad because your brain has already experienced the pain. So I think that depends. Yeah. And the dreaded, I think it's kind of one of the dreaded things you hear about ACL, but it goes faster. The rehab goes faster than you think.
We talked a little bit about an athlete. We're seeing more and more younger athletes have these ACL surgeries, and we as healthcare providers know the ramifications that this could lead to later in life. Are you talking about that to your athlete, or is the doctor usually talking to the athlete about that? What's your experience with that?
Yeah. So like you said, sometimes kids aren't even eligible to have surgery, depending on how open their growth plates are and how old they are, because they do drill tunnels through your growth plates. So that's the initial part. And then I know, and we know 10, 15 years later, you have surgery for an ACL and you can develop early onset arthritis. And so quality of life can be affected by that. And I always just like to talk to my athletes and really explain to them like what's going to go on when they're in surgery, depending on like what kind of graft. Honestly, after I saw an ACL surgery, I was like, no, now I know why your knee hurts so bad afterwards, because they're like yanking your hamstring or yanking the tendon out. And you're like, well, yeah, you just like beat me up kind of. So it wasn't even like the surgery so much as what they had to do. So I really try to go through it with them, explain to them like what we're doing, what we're using, and no kids are thinking about like 15, 20 years down the road when they have kids, they're going to be running around with them and stuff. And I always try to just say like, this could be a thing, or, and so it's just something to consider. I think it's sometimes I have that conversation more seriously with meniscal injuries, because meniscectomies versus repairs, which I'm sure you could do a whole podcast episode on that alone, to try to explain to people like what the difference is and how it can affect you later on down the road.
I think it's really hard as a kid or a collegiate athlete to think long term. I know I myself had a career-ending injury at a Lisfranc dislocation my junior year of college, and I'm not thinking about 20 years down the road. I'm thinking about next year. Like I want to get back to playing. So it's really hard to grasp that and to trust in those people that are telling you these things, for sure.
Yeah, and there's no way to like, obviously they're just gonna have to experience it for themselves. But I always try to just keep like
Plant the seed.
Thinking about it. Plant the seed, like, this could be you later on in life. And the other thing I really want to highlight is to be an advocate for yourself and like know your body and know what is happening to you. I can't tell you how many patients we've seen in the office. I work with one of our orthopedic doctors on, and I'll be like, have you had a previous surgery or any sort of, and they're like, yeah, I don't know, like 20 years ago, I had some surgery. And I'm like, well, do you know if it was like ACL, meniscus, like what it was? And they really don't. So, honestly, I don't know if you want to, older people have lists of their prescriptions written down, but maybe throughout your life, you kind of have a list of, oh, in 2001, I had this thing. And, so that way, when people are asking you these questions, as you do get older, you can remember those details, because it does make a difference. We try not to do total knee replacements on 35-year-olds, obviously, because they don't last forever. But we want to know, someone's history, so that helps us kind of make some of those decisions. So be an advocate for yourself, like know your medical history. So later on down the road, you can tell people.
Definitely. I know you kind of took a left turn there, but I do want to get back to kind of the whole process of an athlete tears their ACL. So you get them off the field. How soon are they seeing the doctor? What's kind of the next steps as far as coming back to work with you or physical therapy, and how you navigate that transition?
Yeah, I think it's definitely different levels of play. If they're high school club players, high school, just high school school players, college, professional. Obviously, professionals have access to anything and everything they want. They're getting MRIs that same day sometimes, so it's a totally different level. So we'll leave those people out because most of the regular people of the world don't have access to those things. But in high school, we can usually get somebody in. What's great about working for a healthcare system like MedStar or any sort of hospital system, as an athletic trainer, I have all these resources. I have physicians that I know, I can call them, I can text them. I have physical therapists that I know and I can, get in to see quickly, people who work more with athletes. And so for me, we can usually get someone in next day to see somebody. And I think the important thing for people to know is you don't have to see an orthopedic surgeon as your first stop. Obviously, at some point you will because they're going to do the surgery, but we have a ton of primary care sports medicine specialists who know all this stuff. They just don't do surgery. So you can start with them. They can get the ball rolling. They'll order an MRI. They'll do those things. And then once we have all the workup done, refer you to an orthopedic surgeon. So, that happens within a day. And sometimes I will say MRIs are harder to come by, within a week we can usually get somebody, but sometimes it's, a little bit more, but, from day of injury, pretty much, I would say by a week to 2 weeks, you can know what's going on and have a plan in place of what you're going to do. For me, one of the things I did a lot of research in. My research in college was about knee rehab and outcomes before surgery. The better you are functionally before surgery, you usually have better outcomes after surgery. So a lot of our doctors will wait until patients, don't have as much swelling. They have full range of motion. They can bend and straighten their knee before they'll actually do surgery. So that can take a few weeks, just depending on everybody's body is different. And then they'll have surgery and then we start the process. So for high school athletes, mom and dad are there every step of the way, holding their hand and helping them through the process. And so, which is great. It's nice to have that. And, so they'll take care of that stuff and they'll, most athletes are getting into rehab, I would say, within a week of having surgery. You're starting doing some at-home stuff. You're starting your PT appointments. As a high school athletic trainer, it can be hard to sometimes keep track of those kids because you won't see them, in the athletic training room, really. They'll be doing all the rehab at the clinic. And so developing that relationship with a physical therapist to help. So you're involved, just keeping you in the loop at the beginning. So that way, as they continue to progress, you can start, they can come to practice and do some stuff on the sideline with you so they can feel more part of the team and they're not like just on their own. In college, most athletic trainers, sometimes colleges employ physical therapists at the college, which is great. So they'll work with the athlete, but a lot of athletic trainers will do the rehab with them. So you'll get them in there again a few days after surgery and just start getting them moving and then follow them throughout. So it depends, I think, on what level, but I think there's a general timeline for some of those things.
And we stress the importance of physical therapy, having relationships with athletic trainers to make that transition more seamless. And also it's a better experience for the athlete as well, so that they're not just the ones relaying information from the PT to the ATC. Like those two should be connecting pretty quickly.
Definitely. I mean, yeah. 15, 16-year-olds are traditionally not great at communication. So a lot of things get lost in translation, if you don't have that relationship set up beforehand. And, when you're a high school athletic trainer, you might be working just for a school on your own. And you don't have access to a network or anything like that. And so, sometimes it takes the athletic trainer to have some sort of, to have some wherewithal to kind of go out in the community and meet some of these physical therapy clinics that are close to their school that their students might be using and trying to develop a relationship with them. And I encourage any physical therapist who's working in an area that's near a high school or something and, stop over there and introduce yourself. I think the best way to develop that relationship is FaceTime, going to the school. Hey, can I come out and watch the practice and hang out with you in the athletic training room? Or athletic trainer, can I come to the clinic and see what you guys are doing in the clinic? Like there has to be some give and take there on both sides. It shouldn't just be like, oh yeah, this is what you have, because I'm so close, you should just refer here or whatever the case may be. Let's, develop some rapport there so that, it just makes everything so much easier when you already have that set up ahead of time.
It's a whole team effort. I mean, we have the surgeon, the parents, the coaches, the athletic trainer, the physical therapist. Did I miss anything? Strength coach.
Yeah.
It's a lot. It's a lot to
Psychologist
manage.
sometimes, depending on if you have that resource.
When we're working with athletes and we're trying to communicate that this is not a 3-month Adrian Peterson recovery, that realistically research shows that waiting at least 9 months to a year is optimal for the health of their knee and their other knee. When you're working with athletes, do they come, we have those conversations, are they coming to you, I'm trying to beat that, or is it kind of a mix of more hesitancy, or they're kind of okay with that timeline?
Yeah, I think you see both. I think a lot of athletes are competitive in general. So I think you're right. Sometimes they're like, oh yeah, they say this long, but I think I can get back in this, amount of time. And certainly there are people who can, right? Like, could you? Can you? Sure.
Should you?
Should you is the question. And I don't know. Again, that answer has changed throughout the years drastically, especially in the past 20 years. I mean, the way we used to 30 years, the way we used to treat ACLs to the way we do it now is very different. And when I had my surgery, I was back in like six-ish months. And at the time, I think that's like fairly normal. And now we have, we think, yeah, maybe a little bit longer is probably actually better. And so it can be a struggle. Once you get past, obviously, when they can't do anything, they're like, sure, I'm just doing whatever you tell me to because they can't do anything else. Once they get to that 3-month mark and they're like, they have full range of motion, they're like getting stronger and there's less pain and stuff. They're like, yeah, I can do all this stuff. And they want to push it. They want to push the plyos. They want to push the running. And that's really what I think it's the hardest is you have to rein them back in and say, hey, I know you feel good. And I'm so glad you feel good. However, your body is still healing. We have to give it the right environment to heal. If we stress it too fast, these kind of things can happen. We don't want to go backwards. We always want to be taking steps forwards. And so I think the middle part of it is the hardest part because you really have to rein them in and remind them like, you're not fully healed yet, unfortunately, even though you feel good.
Yeah, definitely agree with that. When you have an athlete that is getting to those higher levels, like the 6 and 9 month mark, and you're starting to incorporate them into drills, and you don't have the strength coach on staff, you don't have the PT there, how do you work with the athlete and figure out, are they ready for X, Y, or Z? Are they ready for more contact?
Yeah. I mean, I think that's where some of the functional testing that you can do in the clinic is great because that gives you an idea of kind of where they are, comparison side to side. And athletic trainers can do that also, at their high school. You could do a triple hop test. You can do those things and measure them and get an idea of kind of where they are. I always like to use PROs, patient reported outcomes, because people generally know how good they are feeling. They're pretty good judges for the most part. Obviously, some people push it, but when you ask them some of these specific questions, they might not have even thought about that specific thing. And then they're like, yeah, actually, I can't really do that. I never really thought about it. But so that can help too. And then, I think you just start small and you see how it goes and you take gradual steps each day. This first day, we're just going to do individuals where you're not, or just passing something with one other person in you, where you're not introducing a lot of variables for them. You're not introducing, whatever. And then you do that however long, a week, 2 weeks, depends on obviously where you are. And then you just have to keep monitoring them and check in with them every day and pull back. Some days they're going to be sore, and that's totally a normal part of the process. So don't push them on those days. Like your body tells you things for a reason, and we should be better at listening to our bodies because just like when people get sick, well, there's a reason you're getting sick sometimes. So maybe you need to take some rest and relax. So when it's hurting more than, normal, there's a normal level of soreness that comes along with getting back into increased levels of activity, but multiple days of that and all that stuff. Okay, maybe we need to take it back a notch and go from there. I think, yeah, it's just you have to be very communicative with them. There has to be a dialogue back and forth. You're asking them the questions, they're telling you things, open communication.
How much are you seeing, I don't like to use the word prevention, I prefer injury risk reduction, but how much do you see that going on in your world with teams? Obviously, it probably depends on resources and who's on the sideline on that, but curious of your thoughts.
I would say not as much as we could be, probably. As an athletic trainer at a high school, you're by yourself most of the time, and it is really hard. You have however many athletes, during a season. And it's really hard to implement some of those things. You can't be at everybody's practice. And so it can be hard to implement some of those things. And you can train coaches, but I'm here to tell you, every coach thinks it's most important to run the soccer, football drill or whatever. And they don't think the stretching, or they don't think the warm up, or they don't think these other things are as important as we got to do X's and O's. And so that can be a struggle. When you are working more one-on-one with a team, it's a lot easier to have that influence over them. I think more and more clubs for different sports are starting to have prevention or, injury reduction plans, or just like trying to implement something to help, whether it's a better warm up, whether it's a better cool down, whether it's a regen, session instead of an actual practice. And so I think we are seeing it more, but I definitely think there's a huge room for improvement there. It's just so hard with the coaches are really running a lot of what's happening. And if they're not buying in, then it's really hard to implement stuff.
Yeah. And again, I know I keep plugging PTs, but that's a great avenue for the PTs to enter in and get that face time like you were talking about, and provide that education and have a bigger effect there, I think.
Yeah. I mean, and coming out, I can't stress it enough. Going out into the community is the most important thing. Like, obviously, we love to get them into our buildings or our clinics and show them the cool stuff that we have and all the resources we have. But most people do not care unless they need to care. Like, generally, like, until it's you, they're like, yeah. So getting out there ahead of time into the community, reaching out to local high schools and being like, hey, I'm down to come to practice, but all of that stuff happens, 4, 5, 6 o'clock in the evening. Like, it doesn't. They're in school during the day. So unfortunately, you have to give up some of your evenings. But I think in the long run, it's definitely worth putting in that front time on the back end, because you develop those relationships and they're going to go to you right away. That something's going to happen and they're going to call you up and be like, hey, this happened. What
do you think we could do better as physical therapists, either be it communication or working with the athlete in various ways? What could we do better when treating athletes after ACL surgery?
I mean, I personally think they can probably be pushed a little bit more. I think we're hesitant, and a lot of times you're working with a very diverse population where you have 14-year-olds to like 80-year-olds with total knees. So sometimes you can get stuck in, we don't want to push them too fast and stuff. These young kids really are resilient. They're going to be okay. Don't do jumping the second day, obviously, but within reason, you can push them harder. And so I think that's one of the things I see most is like, you could be pushing them more in the clinic. They can handle a lot more than you think. And then, yeah, the communication part, obviously there's a lot of documentation that goes into any sort of injury, at the clinic and stuff. But when you're sending those updates to a physician, maybe CC, or just think about, can I CC this, or can I shoot this over to the athletic trainer too? If you know them, if you have that type of relationship, just so they can, see it as well. I think helps. And then, listening to your athlete, we talk about EBP, or evidence-based practice. And one of the third of that is patient values. And I think sometimes we forget that. We're so based on the research, you're so like caught up in what you've seen before and, how it should be going and stuff, that you sometimes forget that you should be listening to the patient sometimes, just as much as some of those other things. And so, if they're repeatedly telling you something, like they might functionally look really good for, seem to be doing fine, but they continue to say the same thing over and over again. Maybe it's time to like, okay, maybe we should look into this. Maybe we should tell the doctor this. Maybe we should somehow, refer this to a different thing, because patients know their bodies. And, I was telling you before we did this podcast, but when I had a cyclops lesion in one of my knees, which is basically just a scar tissue buildup inside the intercondylar notch. So, but I always felt like I could never fully straighten and could never fully bend. Like, I mean, functionally it looked like I could, and I was getting to 0. It just felt not right to me for whatever reason. And when I got to college, taking classes and stuff, I was like, yeah, I think there's something to this. So I told one of our orthopedic docs, he's like, let's just get an MRI and see. And sure enough, he's like, this is a classic cyclops lesion, which I did not know that was a thing. So we went in, took it out, and literally 2 weeks later, I was like, oh my gosh, I never knew how, like, those 2 degrees or whatever, those minimal, like, made such a big difference. And I was like, oh wow, it feels totally normal now. So I think, yeah, listening to your patients and taking into consideration what they're saying.
I think building that relationship with your patient is so important, to give them the space to feel comfortable to verbalize their concerns to you. So important.
For sure. Yeah. Listening more. I think we could all in the world benefit from just listening a little bit more to each other, instead of trying to have the last word or whatever.
Definitely. Wrapping up here, is there anything we forgot to talk about that you're itching to talk about with regards to this topic?
I think the only other thing, we didn't really talk about the mental aspect of this, but it's huge, and it's huge at any injury. And I think we are starting to recognize that more and have that as part of our treatment plans. But, for me, I didn't hurt myself in contact ever. And for me, going in for a tackle was like really a mind block for me. I was like, oh, I'm scared to do this. And that wasn't even how I hurt myself. So it could be something totally random that they're scared to do, for whatever reason. And they just have this block. So, I mean, I think getting, if someone is expressing some of those feelings to you, referring them to the right people. And I think especially with ACLs, there's a huge comparison game, because it's becoming more and more common. And most people have had friends who've torn their ACL, and then they're like, oh, well, they got back in 4 months and they got back in whatever. And how come I'm not doing that? And you get into this comparison game, and reminding them everybody is different. Everybody heals at different rates. And it doesn't mean you're good, bad, indifferent, or they're better than you or anything like that. Acknowledging where you are, and how far you've come, reminding them, remember when you couldn't do this and now you can. So setting goals is, I think, another huge part of that. But the psychological piece, I think, is also just really important.
Absolutely. So last question we like to ask all of our guests: what is a favorite quote that moves you, drives you, or that you refer to?
So this has been ever since I was in high school. I had a really tough freshman year. I had torn my ACL. Also 2001. And if you remember, 9/11 happened in 2001. I tore my ACL. It was just a hot mess of a year. I got chickenpox at the end of the year. Like, who gets chickenpox when they're 14? Anyway, someone gave me this card, and it has always stuck with me. So it's just when the caterpillar thought the world was over, it became a butterfly. And I just love it because, gosh, life is hard, and it's never going to be all roses and stuff. And I think if you can keep going and you can keep moving forward one step in front of the other, however little that is, eventually, all of a sudden it'll just turn a corner, and it's like, oh, look at all this beauty that was here. And so I love that quote. I think it's great. It's great about resilience and just getting you through life.
Love it. Love it. Thank you so much. This was a great conversation. And where can people find you? Are you on socials? Are you on the sidelines? Where can we find you?
I'm on the sideline tomorrow night at the Maryland Black Bears game. So I'm the athletic trainer for a couple junior hockey teams here in Maryland. So if you're into hockey, they're super fun games. We're wearing Old Bay jerseys this weekend. It's exciting here in Maryland. So that's where you can find me clinically. My handle on Instagram is ARRadtke. My last name RADTKE. That's where I'm at.
Awesome. Thanks so much.
Oh, thanks, Matt.
Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.